And I'm very pleased to introduce Dr. James McCracken. Dr. McCracken is the director of the Child Psychiatry Division here at UCLA, and he's a world expert in pharmacotherapy in a variety of childhood onset disorders, but particularly autism. And today he will be talking about drug therapy and autism spectrum disorders. What do we know? Is precision medicine possible in ASD? So thank you, Dr. McCracken.
Good morning, everyone. My pleasure to be invited back this year by the organizers. I'm glad they felt that I maybe has something to contribute. So in some ways, it works out well for me to follow Dr. Geschwin, because ultimately I'll be talking about what he ended with, which is how to marshal all of this basic science information about the etiology of autism and to use it to direct us to identify and test what we hope will be transformative treatments. But what I'm going to do today is sort of bring you up to speed with the role of drug therapy in the treatment of ASD, and then give you a glimpse of some of the things that we're working on and how we're going about looking for better medications for this condition, or conditions, as you know. These represent my disclosures. So briefly, I'm going to introduce this topic by talking a little bit about why use medications in the first place. What are some of the needs that we're trying to address with drug therapy? And not to make our work seem heroic, but we'll talk some about what the challenges are that we face when we try to do this kind of work. Then we'll, as I said, bring you up to speed on where we have really good evidence for the use of medication in the treatment of autism and associated behavior problems, and then give you a glimpse of what's going on now and possibly the future. Okay, not to belabor this, since many of you are all too familiar with this topic of what are the needs still in ASD, despite the kinds of improvements and advancements in early intervention, the development of other treatments for older individuals. We know that despite best efforts, even with early identification, even with the best early intervention, that most individuals never lose their diagnosis. They can improve a lot, no question about it. But we know that even in the folks who show the most improvement from early treatment, that there are still problems that are very stubborn, very persistent, particularly in the social realm, in multiple areas of social functioning, and other core features like repetitive behaviors and restricted interests also hang around, don't go away, again, despite treatment. The other set of unmet needs relates to things not autism per se, but common hangers-on or associated features. We'll talk about those, but these in some ways are so common to almost be considered part of the core, honestly. The difficulty in regulating emotions, the hair trigger that many individuals with ASD demonstrate when frustrated, their propensity to become aggressive, ADHD symptoms which compromise their ability to perform up to their potential in academics or to get the most out of a therapeutic approach, anxiety and sleep problems. The thing that's also concerning as we've gotten a better understanding about the life history of individuals with ASD is that as these folks enter their 4th and 5th decade of life, the information that we have is that, if anything, adaptive skills decline in later life. Very, very disturbing. Maybe that is just a simple reflection of the fall off in services available. No question that is part of it, but some of the work by Marcia Malik from Wisconsin has shown that literally the peak for adaptive functioning occurs in the late teens, early 20s, and it tails off thereafter. And, you know, if you ask parents simply to rate, what are the biggest day-to-day challenges that you're facing with your youngster or your young adult? Often you'll get back it's their aggressive behavior or their profound anxiety that can't get managed. So all of these things represent, in a way, different kinds of targets for treatment. Medication certainly is not the only approach, don't get me wrong. In all of the examples that I'm going to give you, medication is only to be considered as a part of a comprehensive treatment approach. But nevertheless, these unmet needs lead us to look for ways in which we can improve functioning and reduce suffering. So in order to test a drug, and particularly to sort of go for the home run, if you will, as far as trying to treat some of the core problems that represent ASD, there are some challenges in designing a study. These maybe are obvious to you, but there are things like, if you're going to do your study, what level of intellectual functioning do you want your subjects to have? You know, the range is profound in ASD. Likewise, how severe do you want to select your subjects for as far as their social functioning? And what about some of those associated features? If you're testing a medication, let's say, for its impact on social communication, do you want subjects in your study who are manifesting daily episodes of severe aggression? May not be the ideal subject. So one has to deal with the enormous variability among folks with ASD in just setting up your subject population from the get-go. As you heard from Dr. Geschwin, and I kid him because every time I talk to him, his estimate of the number of genes involved in autism is multiplied by another 2 or 3-fold, and now you heard 500, maybe 1,000. So immediately, as he told you, we wouldn't necessarily expect that one medication would work equally well for 1,000 individuals with autism who might have that many different fundamental causes. So how do you deal with that in a study? And I'll tell you at the end how we're approaching that right now in one of our new treatment trials. And likewise, while genetics is really important, Dr. Geschwin mentioned the environment. And the environment can play a role as well in increasing variability amongst individuals with ASD, things like birth injury that he mentioned. There are other theories as well that are currently being researched, such as the possibility that the fetus might be affected in utero and thereafter by the mother's immune system being activated during pregnancy. A totally different mechanism, potentially, of causation. Do you want individuals like that also to be included in your drug that maybe you're aiming to target more of a particular genetic pathway? And there are measurement challenges, other thorny questions too. How old do you want your subjects to be? Would we expect an adult, maybe 28 years of age, whose brain from in utero has developed, influenced by his or her unique genetic mutations, to be as responsive to a drug therapy as, say, a 3-year-old or a 5-year-old? Hard to know. Obviously, then, we need to do studies across the whole age span, but that poses difficulties as well. And then lastly, how much should we really expect from medication when it comes to treating ASD, and particularly the core features like social functioning, like repetitive behaviors? Do we really expect that a medication on its own, in isolation, not changing anything else, may be sufficient to have a clinically significant benefit if that's given in the absence of a particular treatment? Or should we throw out the way that we've been doing most of these studies and only do studies that pair a medication with a particular treatment, like a social skills treatment running alongside the administration of the drug being researched? Don't know. We're doing things both ways right now, and our hope is that in some ways we might find medications that actually accelerate or improve the effectiveness of psychosocial treatments or psychological treatments. So what Dr. Geschwin was introducing is a notion now that really all of medicine is aiming for, this idea of precision medicine, really personalizing or individualizing treatment based on the unique characteristics of that one individual, their genetics, their whole life history, other factors. And this is where we're heading in ASD too. It's going to take us a while to get there, but really this is our goal. So as an introduction to the current use of medications, let's just point out some of the treatment targets here that, as I said before, are so common and so vexing for parents, educators, peers, siblings, and so on. So outside of the core features of social and repetitive restricted interest, the kind of the basis of the diagnosis, you see a whole host of other common co-occurring problems. Anxiety, mood problems, very, very common. In fact, in some estimates of the rate of anxiety in ASD, you come across figures that 80% of the sample showed high numbers of anxiety symptoms. Others are more modest, but probably in the range of 40% of individuals show prominent anxiety. Sleep disruption, likewise, we'll talk about. Then there's a whole range of what you might just call disruptive behaviors, kind of like hyperactivity, out of control, impulsive behaviors. These also are very, very common. We'll talk about those as well. Aggression, self-injurious behavior, language and communication problems. You can see quickly then that indeed there's a need for a lot of different treatments for a lot of different potential targets. So let's start with and review the four basic places where we have good scientific evidence for the effectiveness and safety of medications. The first is coined irritability, which may really be sort of a euphemism, but I'll describe what that consists of in a minute. So this is the only place where the U.S. Food and Drug Administration has fully approved the use of a drug in the context of autism, and in this case for children with autism with high levels of irritability. What in the world is that? Well, it's things like self-injurious behavior, aggressiveness, prominent mood swings, negative mood, tantruming, and loud, dysregulated behaviors. Taken together, the kinds of kids studied for these two treatments, risperidone and aripiprazole, are this close to being kicked out of their school program, this close to be hospitalized for the severity of their problems. And these behaviors are quite common. Of course, you'll see the whole range of temperament and behavior in individuals with ASD. Some folks are very placid and are not likely to display aggression, but again, in some surveys, looking more across longer periods of the lifespan, perhaps as many as 50% of individuals on the spectrum will manifest these behaviors to a significant degree. And 15% of people on the spectrum, at least at some point in their lifespan, will suffer from severe self-injurious behavior. So that's a lot of people with a very, very thorny problem to be managed. So the good news is that these two medications, as I'll show you, have proven to be very effective in managing this set of behaviors. This is not treating autism, of course, but again, this is helping them stay in their classroom, stay at home, not get hospitalized, not hurt themselves or others. You see here in this study just over 8 weeks of treatment with, I would emphasize, low doses of risperidone, averaging just 2 milligrams per day. You see individuals starting treatment in the risperidone group with a 26, and after 8 weeks, this drops about 60% to a total of 11, whereas the placebo-treated kids had a very modest reduction of less than 15%. So in a treatment trial, this is a whopping difference, suggesting the strong evidence for efficacy of this treatment. I'll point out as well that the benefits are seen very early. If you don't see improvement within a period of time of 2 to 3 weeks, you probably should consider changing horses because usually the improvement is that prompt. Now, the next question is, okay, great, you've got me 8 weeks of improved behavior, how long does this last? And it looks like this benefit is very durable, even without requiring any continued increases in the dose, as seen here. In that study, we actually were able to continue treatment for another 4 months in kids who did very well with the medication. And you see that the ratings of their irritability were flat. No suggestion of the effect sort of fading out over time. And as I said, no need to crank up the dose beyond this more modest dose of 2 milligrams per day. Those results were paralleled by another federally funded study, again with risperidone, this time also going out 24 weeks, 6 months. And interestingly, in this study, they did compare risperidone alone to risperidone plus behavior management training for the parents. And you see the good news, both groups showed a lot of improvement, big drops from baseline. Again, look how rapid that response is. And then the improvements are really sustained over time. And most of the kids were able to continue on the medication. A few, about 1 out of 5, switched to another medication. And overall, the dose, again, really was essentially unchanged. So that looks good. That's not the only choice. Aripiprazole is a second approved medication. And on the whole, it has fairly similar effects. Overall, you see this is plotting out placebo group, changes from baseline to after 8 weeks. And then in the 3 different fixed dose groups, baseline 8 weeks, baseline 8 weeks, pretty consistent decreases. And overall improvement, it was seen in over 50% in this study. To their credit, these researchers also did a year-long study maintaining treatment in this same group of kids who were in the short-term study. And you see here those kids who did well coming out of the initial study also maintained good stability, representing maintenance of improvement over time. And those treated with placebo who just started the medicine showed big drops, which also were maintained over an entire year. So that's the good news. Some did drop out. Fortunately, most that dropped out were not stopping because the medicine lost its effectiveness. On the whole, it showed good maintenance of that improvement. But the next question is, how long do I continue treatment? Is this a forever kind of situation? Well, to be honest, that's one of the questions we have very little information about. However, in the risperidone studies that I just showed you, after 6 months, for those kids who had done very well, we took the first 32 and we randomized half of those to placebo, and the other half stayed on their medication, same dose, and we brought them in each week and reevaluated them, not knowing who was taking what. Lo and behold, those individuals randomized to placebo showed a much bigger relapse, about 60% relapsed. The aggression, irritability came right back. But about a third over a 2-month observation period looked good. So I think the suggestion is that one might be able to stop these types of medications after a period of sustained treatment as short as 6 months, 12 months. At least it should be attempted. There's no need to continue a medication, of course, if it's no longer needed. And doctors need to be challenged to justify the continued treatment by such efforts to reduce the dose and even stop the medication. So are those the only 2 treatments? Well, as I said, they're the only 2 that have FDA approval. That's the highest standard for evidence of safety and benefit. There are some other medicines, some from the same class, the antipsychotics, which both risperidone and aripiprazole represent. The older medicine, haloperidol, was shown in some well-done studies to be effective for similar sorts of behaviors, but we don't like to use this medication because the side effects are even more concerning. There's some newer medicines, haloperidone, olanzapine has been studied in 1 small placebo-controlled trial, and I have to say that the benefit in that study displayed was much less than in the studies with risperidone and aripiprazole. Ziprasidone also sometimes used, simply not studied. Then there are other agents outside of that group, valproic acid, the anticonvulsant, also small benefits in 1 controlled study. And then one interesting finding yet to be replicated is a supplement called N-acetylcysteine. You can get this at your Whole Foods store. And it is believed to work on some of the same neurotransmitter systems that we believe are awry in ASD. There's one well-done clinical trial at one institution, not huge, but it looked like this might be an alternative to consider, maybe in more mildly affected individuals with these kinds of behaviors, the irritability. So good to have options. All right, next treatment target, ADHD. We have to speed up here. So super common, and I have to say often unrecognized, surprisingly, by both teachers, parents, and many clinicians, and yet this is a treatable set of behaviors that is very likely to be quite impairing, both as far as academic performance, but even in terms of things like responsiveness to other psychological or behavioral treatments. We diagnose it in almost an identical way as we would in a typically developing child. So the first question is, do the same medications, the stimulants that we use in typically developing kids work for these kids with ASD with the same set of behaviors? The answer is yes. Maybe a little less robustly than in typically developing kids, but you see here pretty large reductions of about 40% from baseline, good overall improvement, and overall a response rate of maybe 50%. So 1 out of 2 kids will show a really, really good response to a stimulant trial. One other point, though, about stimulants and ASD, there's no question that kids with ASD, and adults too for that matter, are more sensitive to the side effects of these medications. They're not serious side effects from the point of view of medical conditions, but behaviorally they can be so severe as to be intolerable. So one needs to be cautious with this treatment. Another commonly used medication for ADHD is Atomoxetine. Brand name is Strattera. Large European clinical trial, seemed to be well done. Unfortunately, the benefits are weak. Not much to suggest its use in ASD, unfortunately. How about the one other commonly used treatment for ADHD in typically developing kids, Guanfacine. We just finished a multi-site federally funded trial with the extended release form of Guanfacine. And what you can see here in the kids with placebo, looking at their ADHD symptoms, you see very little change after 8 weeks. Fairly large reduction, almost 45%, 48% in the Guanfacine group. So we've got another winner here. About a 50% improvement rate also. Fairly well tolerated, not too many dropouts, with an average daily dose in these 5 to 14-year-olds of 3 milligrams per day. And with our colleague Sandy Liu, we also added cognitive testing because, of course, if you're treating any youngster with any medication, you certainly don't want to impair learning in an already vulnerable population. And the good news here is that while we didn't see big improvements in cognitive functioning, we saw no impairment. How about sleep? This is something that can tear families apart with the severity and persistence of sleep problems that in many individuals seem to be present from birth. Very, very commonly reported in this population, shorter sleep duration, approaching 30 minutes, almost an hour, many more awakenings at night reported. High-functioning adolescents also report 3 times as many sleep problems, insomnia, awakenings. The good news here is melatonin, the natural hormone taken as a supplement, looks like it is pretty effective. And indeed, in about a dozen controlled trials comparing it to placebo, you see benefits on both earlier sleep onset of about almost 30, 45 minutes, and sleep duration is also increased or lengthened by about that same amount. So that's almost an extra hour of sleep. That's good. That's clinically significant, and safety appears to be very good. That doesn't always work, however. Melatonin is relatively mild. It's not a knockout hormone or anything of that nature. And at times we need to look for other possibilities. And there's a host of other medications. Many of these are kind of atypical antidepressants like mirtazapine, the old tricyclic antidepressant doxepin, and trazodone are often used and are pretty effective. Only doxepin has a controlled trial demonstrating this in ASD, and then high doses of gabapentin given in the evening may also be beneficial. But all of these except doxepin are off-label. They're not approved for this use. And then what about repetitive behaviors? And here, of course, we're getting closer to the core of ASD, right? This is part of the diagnosis. Why would one even think about using a medication for a treatment target like that? Well, often despite even the best of behavioral therapies, the best sort of structured environment, repetitive behaviors just run amok and form a barrier between the child and their world, including their therapists, their peers, their family, just by the intensity and the frequency of these behaviors. So it would be useful if indeed a medication combined with other treatments might be helpful. And originally there was the thought that, gosh, these behaviors seem so driven, so internally generated, that it almost appears, at least on the surface, like obsessive compulsive disorder compulsions. That there's just that kind of idiosyncratic, stereotype nature to the behaviors, and the children and adults seem like they can't resist these impulses. So this led to kind of a conceptualization of some repetitive behaviors that indeed they might be OCD-like, and hence maybe they'll respond to the same medications that we use for OCD. We were wrong. I'll show you. But fortunately, there are some medications that at least have a modest benefit. And I have to say, this is an area where we really are looking for much better treatments. Now, it turns out that risperidone, same medication that I mentioned before, in other analyses from these same clinical trials where it was being tested for irritability, showed that it can knock down repetitive behaviors to some degree. In that same study that I mentioned, as you can see here, kids given placebo showed a pretty negligible drop, about a 6% drop from baseline. Kids given risperidone showed about a 25% reduction from baseline. Now, that's not enough to brag about at a cocktail party or to your mom or dad, but it's a significant change that statistically quite robust, and perhaps for some individuals it might be useful. However, that said, risperidone, as we were talking about before, does have side effects. So whether indeed this benefit really outweighs its side effects over the long haul is an open question, honestly. Now, what about aripiprazole, the other treatment? Well, it's kind of fascinating to me, but it has almost the identical effect. About, compared to placebo, a difference of about 20% greater reduction in repetitive behaviors. As you can see here, this represents data from 2 studies, both with a placebo, so rigorous in that sense. You see in this placebo group a drop of 20%, a drop in the aripiprazole flexible dose group. They averaged about 10 milligrams per day of 40%. In the fixed dose study, in which placebo was compared to 5, 10, and 15 milligrams per day, you see again this kind of flat response, but a difference of about 20%, almost exactly what we saw in the risperidone study for its effect on repetitive behaviors. We think that there should be better treatments, or there should be a better way of classifying what repetitive behaviors respond superiorly to these kinds of treatments or to other treatments, but we're not there yet. Like I said, we've thrown out the OCD model for these kind of behaviors. In the most frustrating and disappointing study I've ever done, you can see the results here of using one of the SSRIs commonly used for anxiety and OCD, citalopram or Celexa. You see here the placebo group and the citalopram group. They're just completely overlapping. Not even a hint of an effect. And it took us 3 years to find that answer. So we don't recommend the SSRIs as a treatment for repetitive behaviors per se. So where are we going with the research in drug therapy? There are lots of compounds that are being looked at, and we're trying to, as I said before, be guided by our basic science colleagues and what they are identifying as possibly important pathways or genetic mutations. You heard about oxytocin, which looked so fantastic in the mouse model. Thus far, however, when it comes to studies in humans, the results have been quite mixed so far. But these studies are all pretty small. very different groups of patients involved, some kids, some adults, some just given a single dose, as if that might have a dramatic change, others treating for many, many weeks. The good news, though, is that the federal government has launched a very large trial of oxytocin in children and adolescents. And so in another 3 or 4 years, we will probably get a definitive answer about this. At present, we consider this an experimental treatment. Now, interestingly, though, there's another hormone and hormone system that in many ways overlaps or is also involved in social behavior like oxytocin, the vasopressin system. And based on a variety of different kinds of evidence, there is currently large clinical trials underway of blocking the action of vasopressin in the brain with a very specific medication. It's being studied in adults right now. The company plans to study the molecule in kids as well, and this potentially could also be another treatment. A wholly different group of chemicals is represented by molecules that block the action of the neurotransmitter glutamate at very specific receptors, the so-called mGluR5 antagonist. Now, I'll very briefly describe these studies in a moment, but unfortunately, all of the studies to date with these medications have been failures. So this program is in critical condition, one might say. Now, interestingly, the anti-dementia treatment memantine, or the brand name Namenda, has been explored as a treatment in ASD. And there's some theoretical argument that might support that. There's a large trial that's ongoing involving children with ASD, and they keep expanding the sample. That's not a good sign when companies do that, because it suggests that they're not finding what they were hoping for. And then there's some other very interesting and quite distinctly different treatments that are being explored. One is pregnenolone. So it's a hormone, but it's a so-called neurosteroid that acts fairly specifically on GABA receptors. You heard from Dr. Geschwin about GABA as possibly being important in ASD. I'll come back to that in a minute. But certainly this medicine deserves more study. Also, from some of the genetic pathway research from Dr. Geschwin and others, there are trials underway using a medication called Rapamycin. It's a very targeted treatment. It's an immunosuppressive, so not to be used lightly, but it is a highly rational treatment for kids with tuberous sclerosis because it acts directly on the pathway that we understand to be dysregulated in that disorder. Our Baclofen is another GABA drug that looks like it failed. Minocycline is, again, a very unique treatment. It is an antibiotic, but it has some specific effects that make it a theoretical treatment, but the benefits are weak. And then insulin growth factor is being studied in a very unique genetic subset of individuals. So I'm going to finish just by charging through these last few slides, really just sort of introducing the way in which we're approaching what you might call the next generation of clinical trials. And these are studies in which we really are aiming high. We want to see if we can identify treatments that benefit social functioning, reduce repetitive behaviors and preoccupations. So I mentioned before that there have been some very rational choices for treatments that have been tested and failed. And this just represents 3 three of them here. mGlu-R5 treatment, no difference between placebo and drug treated. Our Baclofen, no difference in clinical global improvement in our Baclofen versus placebo. And then an Ampakine, another glutamatergic agonist treatment, failed to have any benefit on cognitive performance, as you can see here. So why are we striking out? Why aren't we hitting any home runs? Thus far, many of these treatments have been aimed at glutamate. There's, in actual fact, more limited clinical evidence supporting prominent dysregulation of glutamate in ASD. These failures also raise the whole question of how much can we really glean from mouse models? Obviously, that mice don't have autism. We presume that many of these systems that display abnormal or aberrant behavior in these mouse models can be informative, but right now, there's some reason to question at least the extent to which we can run with findings in mice to humans. As I mentioned before, ASD is hugely variable, and most of the studies done to date in people have just taken all comers, little patient selection. We don't even know if we're using the adequate amount of the drugs in most of these studies. And some of our measures are not so great. And likewise, many are being performed in adults who might have lower capacity to really show a big change with the treatment. So right now, one of the areas that we're focusing on heavily here is using some experimental medications to target GABA, and a particular subtype of GABA. There's a lot of reason to focus on GABA. Studies from human tissue show reductions in a number of GABA-A receptors in the brain. You don't need to be a microscopist to see that there's a prominent difference with lower binding, or as shown in the right-hand panel in individuals from autism with the brain tissue versus controls. In animal models, treatments that improve GABA functioning lead to improved behavior. And even in brain imaging studies, looking at these receptors show reduction just like in the postmortem studies. And when we use magnetic imaging to measure GABA in the brain, we also find evidence that it's reduced. So we're hoping that by requiring a lot more of a potential treatment as far as its rationale for a study, that we will turn up and at least hit some doubles and maybe even a home run instead of encountering some of the failures that we've had so far. And one of the ways that we think we're going to set ourselves up to do a better job is by selecting patients differently. In this case, in our current adult study and in our child study that will be starting in the fall, we're actually selecting adults and kids by virtue of their EEG. Now, the EEG is prominently regulated by GABA. So we're treating the EEG as, you might say, a reflection of GABA function in the brain of these individuals. And we've developed a marker with Sandy Liu and her colleagues that is quite good at differentiating a number of adults with ASD from controls, with a sensitivity of about 70% and good specificity for ASD. So those are the individuals that we're bringing into the study, because we believe that there's a high likelihood that they have the kind of GABA dysfunction that our medicine is designed to treat. So to summarize then, we are slowly but surely developing good evidence for the role of drug therapy in autism. Right now, we can't aim at the core deficits. We don't have a treatment yet that's shown effects there, but we're getting better and better at treating some of the very, very thorny problems that commonly accompany ASD. We have to realize that no matter how good our medications may be, that there are limits to what a drug can can undo or improve. That's obvious, but we can't oversell these treatments. And I think the most important thing is from work that you heard from Dr. Geschwin and others, as we learn more and more about the basic causes of autism, that is most certainly going to point us to better and better treatments. So thank you very much.